So I will go over a few slides on why we funded the study. We have few housekeeping tips. The slides and the recording of today's seminar will be posted at this website. If you are not speaking, please mute yourself. You can use the chat box to enter your questions and comments. If you are calling in, please send me questions and comments to my email. We will handle the question and answer at the end of the presentation. Today's agenda, for me, I will be giving a short background and introduction, followed by the research team presenting research overview of the project. After their presentation, I will give some summary finding slides. And after that, there will be Q&A session. Movements of goods through ports in Southern California, we know it's an important part of the economy, but this can be also a large source of pollution exposure, especially the communities that are adjacent to these pollution sources. These communities can be burdened by disproportionate exposure to pollution from these good movements and also traffic and local industry. This project is a follow-up to a previous CARB-funded study. The previous study investigated a statewide, which was throughout the state of California, to look at asthma impacts. We know that asthma can have impacts not only on health, but also on the economy in the impacted communities in California. There are studies that have found that air pollution can increase asthma symptoms and asthma onset. In this study, increased asthma impacts were seen with exposure to goods movement pollution in Southern California's vulnerable communities. The result of this project will support CARB regulation and policies to reduce emissions from port and rail operations and other good movements activities, particularly in the environmental justice communities. The information that will be gained from this contract can be used to include respiratory disease symptoms in adults as a new endpoint for CARB health analysis. Dr. Su is the senior researcher and principal investigator in the School of Public Health in University of California, Berkeley. He has experience in GIS, remote sensing, programming skills to process large amount of data. He has also experience in machine learning, modeling, and biostatistical analysis skills. Dr. Meredith Barrett is the Vice President of Population Health Research at ResMed, which is a digital health company. She has experience in using digital health data to understand and improve health outcomes in impacted communities. At Propeller, she leverages digital inhaler sensor data to see the pattern of respiratory disease. Dr. Shadi Ashlebag is a postdoctoral scholar at UC Berkeley School of Public Health. She has worked on projects funded by Jet Propulsion Laboratory, NASA. She has also gained experience in the field of spaceborne and airborne remote sensing. There is another consultant, RAM, which is Regional Asthma Management and Prevention. Joel Arvis is an associate director of RAM. In partnership with RAM directors, Joel manages organizational activities to reduce the burden of asthma with a focus of health equity. He oversees two strategic areas, healthy air for health and health equity. So as you can see in this slide, this is the order that the researchers will go over their presentation. I would now hand over the presentation to Dr. Su. I will stop sharing my slide here. Yeah, Dr. Su, you can start your presentation.
Okay, thank you.
Thank you.
Here. Okay, can you see that?
Yes, it's full screen.
Okay. Thank you, Lajis, for your introduction. Thank you, everybody, for attending today's seminar. So we mainly will introduce what we have done for this research project. Next slide, please. So we do, as the largest, only introduce somewhat. So we know for the last decade or more than a decade, so the regulations and also technology advancement have made a huge impact on reducing the levels of air pollution. But in another aspect, we have seen a huge impact or increase in roadway traffic. And the port cargo and also river operations have increased significantly. So that's one thing why we want to focus on port crafts and also the railway operations on the impact of the people's health. Previous studies have typically used more than 90%, I think, used individual's home address as location or exposure, but that exposure cannot be fully captured the people's activity space out of home. So that's part of the reason we have this one. And also we have an interest. It's that's it. The individual level exposure and also the ecological analysis, like at zip code level, tends to be comparable. Which one is bigger? So we wanted to have both types of data being incorporated and have a comparison. Next slide. So our objective is that this product, we have we're very lucky to have RAMP to collaborate with us. So we use RAMP as a contact point to connect with communities and to have a huge input on this product, provide research objective, or sometimes the identify the sources of impact from the community and also provide suggestions on what we have been doing for our research. So that's the community part engagement. So for the research we have been done is that, okay, over here, we have two types of outcome. One is rescue medication use. That's at an individual level. Okay, we identify the impact of NO2, PM2.5, and air toxics from all sources on the impact of rescue medication use. Those are daily. And also we extend this analysis to the statewide. So so it's more population representative. Also we could have some comparison with the previous contract has been done. So that's one is the on rescue medication use, but also rescue medication use not from the whole source, but from the source-specific impact, like NO2 and PM2.5 from port crafts and locomotive operations. But that one is only focused on Socal due to the stalled dispersion modeling limitations. That's rescue medication use, right? Similarly, we also assessed the impact on ED visits at zip code level. So yes, they include impact of NO2, PM2.5, and air toxic from all sources. Those are modeled through non-use regression models. And also the NO2, PM2.5 only from port crafts operations, operation locomotives on ED visits. So that's only for the Southern California. We also investigated the disparities in air pollutant exposure. So on individual level rescue medication use and also zip code level asthma ED visits to see if there's any stratification effect of air pollution and social deprivation on the outcome. So these are the overall project objectives. Next slide, please. Okay, and the management flow. So I'm the PI. So we have Dr. Meredith Barrett from ResMed. She's the one like provide us with all the health outcome data and helped instrumental impact on the health outcome analysis. I'm also act as the overall project manager, but also was responsible for exposure modeling. So worked with Charlie to model spatial temporal variations of NO2, PM2.5, and atoxics. Shorty, Shorty has been doing great, and now she has accepted a position at California Energy Commission. We are very happy for her, but potentially we can still work together in the future. We are close, related for with the research field. She and I have been doing. The next slide, please. Okay, for this project, we have the huge impact of the from the local communities through the community outreach actions, and also provide us with the not only for impact for the current project, but also have impact on the ongoing project we have been working. So I will give this mic to Joe to talk about the community outreach part. Joe, you can take over now.
Great. Thanks, Jason. First of all, can you all hear me? Great. All right. Hi, everyone. I'm Joe Levis, the Associate Director at RAMP, Regional Asthma Management and Prevention, and it's really a pleasure to be a part of this project and to connect with you all today. Next slide, please. So just a little bit of background about my organization. We are a project of the Public Health Institute based in Oakland, and our mission is to reduce the burden of asthma with a focus on health equity. So emphasizing both prevention and management, we build capacity and create linkages and mobilize networks to advocate for policy and systems change that target the root causes of asthma disparities. Next slide, please. We have three goal areas. The first is healthy and stable housing, which involves advancing comprehensive policies on housing quality and affordability and tenant protection. We also do a lot of work related to outdoor air quality and healthy air for all. So that includes shaping policies to reduce and eliminate exposure to air pollution in inequitably burdened communities. And then our third and final goal is healthcare equity. So we increase access to prevention-oriented services within healthcare, and also advance workforce development for community health workers, promotoras, and other asthma professionals. I wanted to provide a little bit of context about the work that we're doing, which will help explain our role in this project. We don't provide direct services to people with asthma, but we support those who do. So as part of our building capacity work, we keep the asthma field abreast of best practices, opportunities, research. We also create and disseminate tools and models, provide strategic guidance, and facilitate training and technical assistance, through which we hope to increase the collective impact on reducing the inequitable burden of asthma. We also create linkages among partners for peer learning and collaboration and network building. And we also, as part of this work, create connections across different issues and sectors to help essentially reduce silos and advance more comprehensive solutions. And then lastly, we mobilize networks to advance policy and systems change. So we advocate and lift the voices of our asthma networks and partners for policy and systems change to address asthma disparities, and social and environmental inequities.
Joel, I don't want to interrupt you. If you could please increase the volume. People are saying
sure. Is that a little bit better? I'll hold up my microphone. Is that better?
Yeah, that's better. Thank you.
Okay, great. Yeah, thank you for letting me know. So in terms of our role in this research project, our connection to the asthma field is really what connected us to this project. So before the research started, Jason and Meredith and the research partners approached us about RAMP serving as a bridge to the broader asthma community. So the intent was to inform the study's design with perspectives from asthma stakeholders in order to make the research more effective and to help confirm that the researchers were asking the right questions and looking at the right data. Next slide, please. So as for how we made those connections to the asthma community, our approach had two steps. First, we reached out to asthma-related organizations and coalitions in communities across Southern California. And then second, we arranged and facilitated meetings for the researchers to interview representatives from these organizations and coalitions. Next slide, please. So here's a list of the organizations and the coalitions that participated in the interviews. As you can see, a very diverse set of organizations and coalitions participated, from community-based organizations to medical clinics and hospitals, to asthma coalitions, to environmental justice advocates. It was a really great group that worked with us, and all of their perspectives provided some helpful on-the-ground feedback to inform the research. And to tell you a little bit more about that process and the findings from the interviews, I'll turn it over to Meredith.
Great, thank you, Joel. And again, Meredith Barrett, VP of Population Health Research at ResMed. But I did want to just highlight and thank Joel and RAMP for participating in this project. They were absolutely essential to help connect the research to the community input process and get that stakeholder input. So just wanted to really thank you for that. So how we made this work after the connections through RAMP, then we were able to host interviews with the asthma stakeholders, and we had about 1 hour interviews. There were 12 different organizations, as Joel mentioned, with about 14 asthma professionals total. So some organizations had multiple people attend those conversations. And again, that included asthma educators, clinicians, community organizers, a number of different roles in the community. We aim to really understand and kind of assess perceptions on multiple topics, including the understanding and perceptions about air pollution, including its impact on health, and namely asthma. We also had discussions about specific sources of air pollution in their specific community. We wanted to get that input early on in the research process. And then we also talked about kind of their behaviors and beliefs around information seeking about air pollution, as well as the exposure reduction strategies. And we also wanted to get a sense for how aware these professionals were in terms of statewide air pollution policies. So that was kind of the themes or the topics covered. We recorded all of the interviews, transcribed them, and then analyzed them through 2 rounds of focused qualitative coding. And those were conducted by 2 independent coders, not any of the folks on this call, but two analysts who independently analyzed the transcripts. And then those themes were identified. So, oops. Yep, great. Okay, so then, so the 6 main themes that were identified across these 14 professionals, we did identify that all of the asthma professionals were very well aware of the negative effects of air pollution. However, we did see quite consistently that they found it challenging to follow kind of day-to-day air quality changes in the communities that they served. We found that they expressed and understood the importance of educating community members on air pollution, especially as a trigger for asthma exacerbations. And the stakeholders also perceived that the communities that they were directly serving seemed to be more heavily affected by air pollution than perhaps other communities across the state. The professionals did not have as much awareness of state level air pollution policies affecting the communities they work in. So that was an area where they kind of expressed interest in learning more. And then they also acknowledged, as we kind of walked through some of the specific sources in their communities, they also did acknowledge that some of those sources, for example, goods warehouses, did provide economic opportunities to some of the community members. That did come up a couple of times. And as I mentioned, a number of specific air pollution sources were identified in each community. So in all of the interviews, we actually would pull up a map and we would talk through and just ask them to kind of name and run through some of the specific sources that they might have concern with about air pollution in their own specific community, whether it's goods movement warehouses or industrial activity or specific freeways and major roadways. And that certainly helped to inform the current research project, to help us think about getting the full breadth of sources that could potentially be at play in these communities, hear about how they think about those sources. And so we're currently working through a geocoding process, so taking that kind of contextual information, geocoding it and mapping it, and that will be one of the follow-ons to this project, is to really map those perceptions, so then we can kind of match that up with research findings from the project. So from this work, we really feel there are several important opportunities to connect the research back to community stakeholders. First, we're going to be sharing our research findings to really affirm their perceptions about air pollution sources, as well as the impact of disparities in their communities. And then also to really affirm that understanding of the health impacts of air pollution exposure on asthma in their communities. We also identified that several important opportunities. So really the opportunity to identify and connect stakeholders to that daily air quality information is one opportunity. Also really supporting stakeholders in information sharing between communities, so really for cross-community collaboration. And I think that lines up really nicely with some of the primary goals and strategies of RAMP, a key part of the Asthma Coalition network that they have operating across California. And then lastly, helping stakeholders stay informed about state level policy opportunities, what's in place, what's being voted on, so that could really impact the community level air pollution, and they can also help participate in any advocacy. So we wanted to thank the stakeholders. This work has informed the research analysis. We've also published abstracts on the work so far, and we aim to, again, publish these perceptions and the maps, as well as publish papers. Input was very helpful, I think, especially in identifying specific sources, highlighting, adding in the air toxics to the analysis, and really honing in and exploring that disparities impact of socioeconomic disadvantage. And also just the need to then turn these findings back into these stakeholders so they can turn it into impact for the people that they serve in their communities. So I will now hand it back over to Dr. Su to walk through all of the exposure assessment work.
Okay, thank you, Dr. Barrett, for the initial analysis on the community outreach results. Those are very interesting. It's like a mapping technology, but I have never seen this kind of survey be incorporated into spatially. It's a very innovative way. I think we will have very interesting paper coming out of that. Now, for me, I spent the majority of time doing the exposure assessment. So there are two types of model over here. Like I said, one is the all source land use regression model that focuses on NO2, PM2.5, and air toxics. As I said before, we extended that to the entire state, so it can be comparable with what we have done before. That's one type of model, all sources statewide. Another model is the dispersion model that only focus on the Socal area, so identify source-specific impact of ports and also railways and the health outcomes. Next slide, please. So I'm going to get into some of the details. So for some of you, if you do not know land use regression model, it's basically you have a monitoring location, emergency concentrations, either by government regulatory monitors or research saturation monitors, or some of the Google streetcar monitors. So they have the emergency concentration. So what for us is to try to identify the impact factors that impact the emergency concentrations. So there's one key factor. You identify all the sources, but one key factor in doing land use regression model, you need to build buffers. Buffers, that's the so you can have different buffers. For us, most time we use circular buffers around emergency concentrations, find its optimal impact or optimal impact or predictors or the environment on the emergency concentrations. Next slide, please. Okay, for land use regression model, so basically we need to identify air quality monitors and connect emergency concentrations, right? That's one. And then you need to process potential factors that might have the impact on emergency concentrations. And then for that part, we have the buffered analysis. Because the buffered analysis in my research doing through coding, one predictor, you can have like from 50 to 5,000 meters, 100 buffers. So entire process will create thousands of predictors. So we need to use a data reduction strategy to reduce the number of predictors. Then, but also another thing, we need to incorporate different types of modelings, different types of monitoring networks. For me, I mostly incorporate those from government regulatory monitors, data from the saturation monitors, and also data from the Google Streetcar monitoring network. So then we apply kind of DSA is machine learning algorithm to identify the predictors have the most significant impact on the outcomes of the merger concentration through a V-fold cross-validation techniques. So once the model was built, then we use the model to predict concentrations throughout the entire California. If that's a domain or for or the area of the study, then get the concentration. But for this one, we develop daily models and also services for NO2, PM2.5. For air toxic, we develop monthly models and services. I don't want to spend too much time on this because sometimes it can be technically challenging. If you still have questions, you can email me, we can talk later, or for potential collaborations on this kind of model for research. Next slide, please. Okay. For the potential predictors, like for NO2, so you have the land use will have impact, right? You have impact on land cover, but also you have the traffic. So for this ones, this data are at a very high resolution, at a 30-meter resolution. So we also create the buffers for each type of predictors. Then that's the high resolution predictors. So it has buffers. But for those ones like a coarse resolution, like meteorological conditions, 4 kilometer, then there's no point to create a buffers. Then we just used the data as it is based on the location of the monitors. We derived meteorological conditions, but also the vegetation index. Also, we have some indirect measurements as predictors, like for PM2.5, you have the aerosol optical depth data, and also for NO2 and the PM2, NO2 and ozone. For now, this one is only for NO2. We have ozone monitoring instruments. We have also some other data, and those ones are non-buffered, but still there are some other types of data that might have impact on merger concentrations, like the elevation, distance to coast, distance to highways, distance to ports, and the location category. We can, I'm not going to get into detail, but if you have interest, is the location category categories those very close to highways, those ones in between highways or the close to major roadways, but how far away from highways. And the third category is the locations are very far away from those two categories, or they have little impact of traffic. So these are all the potential predictors or impacts on the merger concentration. We use them in our non-use regression modeling techniques. The next slide, please. So for NO2, so we have 3 types of monitoring data. So one is the California Air Resources Board regulatory monitors. So we have 113. We also have the saturation monitoring data we have done throughout the years, including those ones in Los Angeles, in San Francisco Bay, and also some of them in Sacramento areas. For the Google Streetcar data, we also have those ones in San Francisco Bay, in Socal, and also in Central Valley. Okay, next slide, please. So basically, we use the non-use regression model integrating 3 types of monitoring data and also incorporate all those potential predictors plus potential buffers. So we create a non-use regression model for NO2. So adjust R squared is 0.8. That's quite high. But this is also for daily. It's a daily model, but also create the daily surfaces. And also put railway emissions. That's part of the predictor we haven't been incorporated before in our previous study. So we added that. But the adjusted R squared is significantly high or is very effective in predicting daily pollutant concentrations of NO2 throughout California. Next slide, please. So this are the snapshots of the surfaces. So the left one is daily. I have also zoomed into 2 parts. One is San Francisco Bay, another one is Los Angeles. I also aggregated them to monthly. So you can see the monthly, and also go back to annual. If you do not look into detail, you might seem similar, but you can still identify. If you look into the details, you see the winter ones, those January ones are a little bit higher than the annual average. That's due to the NO2 concentrations are normally higher during the winter time compared to summertime. PM2.5 would go opposite way. So this is the result. But also this is not what it shows you only for year 2000. So it's 2012 for 336 days. But we developed the models and the surfaces across the years of 2012 to 2019. The data is huge. We could share with any of you who have interest in your research. But you need to have around 20 terabytes of storage space for us to be able to share the data with you. Next one, please. So for PM2.5, for this one, this project, we only used government regulatory monitors to build a non-use regression model. For the ongoing model in which with UCLA Biarritz as contact PI, we are incorporating the Google Street Car mobile monitoring data too. So next slide. So we use a similar way, build a non-use regression model. The adjusted R squared is 0.65. It's still quite significant. It's very effective in modeling or predicting daily concentrations of PM2.5. Next one. Okay, these are the some of the daily, monthly, and annual surfaces for 2012. You can see the Central Valley typically have higher concentrations than like West Coast, but you can still see like Los Angeles typically have higher concentrations than San Francisco Bay typically, and also on the east side, the seems high. Those places might due to a lot of impact of dust, and other impact factors like vegetation. But those other places typically do not have much population. So for us, our own goal is mainly predict concentrations accurately for places with large urban areas. So go next one, please. Okay, we also modeled air toxics. So I saw some of the experts from OEHA. So I would like to have their input or maybe collaborate on the ongoing projects modeling air toxics. So the reason for us to model air toxics is that in California, you have so much of impact of industries. And you have huge transportation hubs, and also the urban cores. So those places are normally have hugely populated, so very close to the population centers. And further, and also another those places has high density or highly populated with low socioeconomic status population, so might be disproportionately exposed to air toxics because due to proximity. We all know another scientific research have identified that air toxics are carcinogens that can impact the people's health. So in this one, so we try to evaluate the impact of air toxics on health. Health is basically two types of health. One is the rescue medication use, and another one is the typical nerve ED visits. Next slide, please. Okay, for air toxic modeling process, so we use the same predictors or similar predictors as what NO2 and PM2.5 have been incorporated. But we also used, because some of the point sources like the chemicals refineries and the petroleum. So all those things, what we used is based on the SIC codes. The SIC code in ArcGIS to provide for each point source what's the sales volume. We use that as a part of the predictors. And the air toxic, what we included, including chromium, that's a total chromium, and lead, nickel, zinc, and benzene. When we did the air toxic modeling, we found they have kind of varying prediction powers. Some of them are low, we can say, but the benzene is one consistently high. So just R squared reached 71%. And next slide, please. Okay. So for this one, the when we do air toxic modeling, we found some of the air toxic could not be effectively modeled. Then during our like a community outreach, some of the stakeholders mentioned the sources of the impact on the communities. We went back and check what specific source over there, try to also compare what kind of data could we enhance. Then we found we could, for the ongoing project, we are collaborating with UCLA. We could enhance our air toxic modeling, like from the emission factors for industrial point sources. So we could also add population density to impact further for those places with like parcel data. We could or remote sensor data. We could add building height, building density to see if we could enhance air toxics. At least for one, once we added the impact or emission factors of those point sources, we removed those SIC codes impact because those sales volumes basically do not align well with the modeled, or the correlations do not high with measured concentrations. The emission factors provided by COP is much higher correlation. So we found the model improved significantly once we removed those SIC codes impact, but also used the emission factors data. That one was done from another small project in collaboration with UCLA professor on cancer risk. So, but the air toxic modeling improvement will be somewhere. Will be in the coming or ongoing project in collaboration with UCLA. The other rates. Next one, please. Okay, now those are the non-use regression model. Now we talk about different model now. Okay, non-use regression models are all sources. So as I have sink, they have the source. But now the talk about stilt. Why we need to use stilt? Because the for the non-use regression model, it cannot identify specifically only the impact from port operations and the railway locomotives, right? For us to be able to identify source specific, we need to use kind of dispersion modeling. So you only have one type of emissions you wanted to model. So see how it spread based on the meteorological conditions. The stilt model is called stochastic time inverted like a ranging transport model. It's different from typical dispersion model. Typical dispersion models, they go from wall to wall. But a stilt model is a kind of receptor based. That means for a point of interest, like over here show, it's kind of the dark orange over there. That point, if you have a point over there called a receptor, what's the impact to that point, the concentration from surrounding emissions? So it basically is have a point. You use all the meteorological conditions to driven the pollution to the point of the receptor with the impact. So basically, it's the so the receptor is basically downwind of the upwind meteorological condition impact of the particles. So then once this is called a footprint. So once you footprint, the good thing of the stilt model is that once you get the footprint, you can overlay the emissions at different time periods, and then just multiply them, add them up, so you get the concentrations. So it's typically computationally efficient than most of the wall-to-wall dispersion modeling techniques. Next slide, please. So for stilt model, there are two typical type of data. One is meteorological data. So we used every 6 hours, and also the emissions data. So over here is from the Socal region. It's specific emissions from port operations and operations of railways for NO2 and PM2.5. Next slide, please. Okay, for meteorological conditions, we use her data is 3 kilometer resolution. So it's basically high resolution rapid refresh model data from NOAA. We used 4 seasons for several years: spring, summer, fall, and winter, and also every 6 hours for a day. Okay, that's 3 kilometer resolution. Next slide, please. Okay, the emissions, as I said, the emissions are the emissions provided by California Air Resources Board. The emissions were at sub-regional level, but we extrapolated to a spatial based on the specific distributions or railways or ports within that sub-region. Now, this is how stilt model runs. Mine is to see if we could click, yeah, to see if it goes. Okay, okay, it doesn't work probably. Okay, so basically, the idea is, okay, for a receptor, there are like the points, the red dot over here, how you use the stilt model. So it's have a receptor, we use 500 particles to track backwards based on meteorological conditions, backwards to the point of impact. So you create a basically footprint. Then you just apply the emissions on top. Use the multiply footprint. Footprint is the contribution of the all upwind area on the point of the receptor of interest, and then you multiply by the emissions. So you get the concentration or total contribution to the point of interest, and then you get the concentration. So next slide, please. Okay. So for Socal, we used all the sensor tracks in Socal. So it's 4,841 basically receptors. Okay, those ones have the impact. So for several years, and several years of daily and sub-daily data. So it's a lot of calibration over there. Next slide. So we still model. Once we modeled, we aggregate to monthly for the years from 2012 to 2019. We still was like still the model and also other models, dispersion models. We wanted to see how accurate those models are, right? So we used around 2,000, even more than 2,000 observations from 19 sites. Those 19 sites are government regulatory monitors for NOx, and also around 1,500 observations from those 16 sites for PM2.5 mergers. And the compared the accuracy. So we found the adjusted R square is 86% for NOx and 54% for PM2.5. So that's actually quite accurate for our modeling, still dispersion modeling. So when we try to select those the calibration size or comparison size, we try to select them far away or far away from population centers, or those ones close to highways, but select them very far away, not very far away from the highways, but very close to the railways or ports. So those are the step-by-step process, what we have done. Next slide, please. So this, because we use the sensor track centroids as receptors, so we modeled the concentrations are at the sensor track level. So for ports and railway operations in Socal. So on the right side, you can see some of the aggregated surfaces. Next. So basically, for task one is exposure modeling. We have two types of models. One is all source non-user regression model for NO2, PM2.5, and air toxics. So NO2 and PM2.5, so I can say very effective predicted, but for air toxics, a varying degree of effectiveness. We are trying to improve the predictions on air toxics. This improvements will come to the ongoing project. It's funded by COP, but UCLA Belarus is the contact PI. So we also modeled the source-specific concentrations of NO2 and PM2.5 effectively. Those ones are modeled through still the model impact of port operation of railways, the pollutant concentrations. This is task one, exposure modeling. If anybody, sometimes might be technical, I tried my best. If you have interest for further discussion, email me. We can have further discussions. Anybody wanted to have the data, we can talk about that too. But you have a huge storage space for you to be able to accommodate the data what you wanted to. Okay, I think next slide. I think now I will hand that over to Dr. Barrett for health data set and health outcome analysis.
Great, thank you, Dr. Seo. So now I'll be walking through the approach and the results for task 2, which was the health data set and analysis of the health effects. So as you just heard, Dr. Sue has developed some of the most detailed exposure surfaces really ever developed in California, very diverse input data sets, as well as very high resolution surfaces for multiple years, both statewide as well as in Southern California. So that really begs the question of, well, how can we use these surfaces to then evaluate what effect air pollutants, different air pollutants from different sources have on various asthma outcomes for California as well as for Southern California. And specifically, how much are these air pollution effects really modified by socioeconomic disadvantage? So that's what we'll be spending the next little bit discussing. So we aimed, again, to evaluate the association of air pollution exposure with asthma outcomes. And there's a lot of kind of nuance about different levels and different sources and different health outcomes. So I wanted to start at the top, kind of at a high level, describing the different air pollution sources, outcomes, and then the socioeconomic stratification. And then over the next several slides, we'll be walking through each step in the analysis in detail. But so we did have, again, air pollutants defined from different sources, as you heard from Dr. Sue. So we had nitrogen dioxide and PM2.5. Those are from all sources, as well as, which is inclusive of port and railway sources. And these were estimated both daily at the state level. And we also have port and railway sources of NO2 and PM2.5. And these were estimated monthly for the Southern California region only. And then lastly, the 5 air toxics, and those were estimated at a monthly level statewide. So benzene, chromium, nickel, lead, and zinc. And so those are the air pollutants we'll be focusing on. We evaluated the effect of these air pollutants on 2 different types of asthma outcomes, and I'll talk through those. First, we looked at rescue medication use as collected by digital sensors from 2012 to 2019. And I'll talk through that source. But these are all kind of summed and averaged to a daily level for both Southern California as well as statewide. And secondly, we used asthma-related ED visits per zip code in California. And that comes from the Healthcare Access and Information from the California Department of Healthcare Access and Information. And that covers the time period 2013 to 2019. Those are on an annual and statewide level. And then lastly, we also wanted to explore the interaction between air pollution exposure and socioeconomic disadvantage. So we will talk through all of that. So first, I'm going to describe the first outcome, which is the individual level daily rescue medication use. And the data, they were collected with consent from participants involved in programs with the digital health company called Propeller Health. And Propeller is a connected health platform focused on respiratory disease, so both asthma and COPD, really aiming to help improve self-management as well as inform clinical care of these respiratory diseases. Their goal is really also to improve public health understanding of different community level drivers of respiratory disease. So that's really the purpose of using this data here. Propeller was founded in 2010 and has more than 10 different FDA clearances for the sensors and the platform, as well as the analytics behind it, as well as regulatory clearances in the EU, Canada, and Australia, so operating internationally. In the US, Propeller has enrolled over 120,000 patients onto the platform and has really focused on using that data for research from the beginning. So how does it kind of work? This is relevant for the data analysis today. The main hardware component of the platform includes the sensors, and the sensors are Bluetooth enabled, and they wirelessly sync and send data to a smartphone. The sensors can also sync with a wireless hub, which enables people who may not have access to a smartphone the opportunity to still sync their data and have the benefit of the platform. The sensors store all the de-identified information, and then once they've synced with a device, the device then sends the information to the servers to process. And from that, they generate analytics in terms of identifying specific triggers for an individual, trends in rescue medication use and controller medication use, alerts about potential impending worsening, potential exacerbations, and all of that information is shared back with patients, with their providers, and also caregivers. And so it's an opportunity to have this kind of objective and passively collected inhaler use data that doesn't require, kind of burdensome record keeping from an individual, but rather just passively collects the information when the medication is used. And again, the sensors are in different form factors. They fit either as an add-on or as an integrated sensor on a number of the different form factors. They currently fit over 80% of the different medications on the market. And these are both the rescue medications that people take when experiencing symptoms, really for acute relief, and then also for the more regular controller medications, which patients take to kind of maintain more control of their disease. So it covers both of those. And tracking rescue use can be quite helpful for an individual, and as well as their self-management and clinical care for each rescue inhaler use, because we're able to collect the date and the time, the number of puffs, as well as when connected to a smartphone, we can get the GPS location of use. That then enables us to really place it into the context in which that medication use occurred. And so that allows that in this research project, for example, to really understand the weather conditions in which that medication use occurred, as well as the air pollutant and air toxics potentially present. And so again, that information goes back to the individual. I do want to also point out that the sensors track the use of the medications, but the sensors are able to track the non-use periods as well. So you do actually get that sort of, the sensor communicates and just says, hey, I'm still here. My battery level is fine. I'm still able to collect information, but I haven't been used in the past for 6 hours. And so that is a really helpful kind of non-use signal that helps us to understand the true use of a medication within a day, which then can be better refined in terms of exposure signals for the day as well. Just again, another point on why we think this is an interesting health outcome to study. The rescue signal is quite useful. It's a frequent outcome, so it represents essentially kind of symptoms for a patient, and we see this occurring frequently. So on average in Propeller data, we see patients using about one puff a day. So it's almost kind of an everyday or multiple times a week. That is quite frequent. And the rescue inhaler use signal can also be, it's used for the acute relief of asthma symptoms, such as shortness of breath, coughing, or wheezing. So it can kind of serve as a proxy for these symptoms. Rescue use has been shown to be an important marker of asthma control, as well as a marker of future adverse outcomes, such as exacerbations or other clinical worsening. And the rescue or SABA signal has also been correlated with clinically validated asthma assessment tests, such as the asthma control test, as well as the COPD assessment test. So able to kind of correlate that passively collected signal with a self-reported signal from an individual. And just last point on sort of the use of this data, Propeller has been interested in leveraging this de-identified data to help inform public health research. We've done a number of projects. Many of them are in collaboration with Jason, just looking at various air pollutants in different regions at different scales, and have found very consistent and significant associations with air pollution in different areas. So happy to provide any of those if anyone's interested. So now getting to the cohort that we studied here in this study. And I'm going to talk about two different scales. So we have the statewide participants, and then we have the Southern California participants. So first, for the statewide, the sample was just over 3,500, so 3,521 participants. It was really primarily asthma. 89% of the sample was asthma, 11% COPD. Largely female, so 69% female, a mean age of 39.7, but really that range was quite broad, from 5 to over 90. 63.8% of participants had a controller medication recorded in their medication plan. Either they were actually tracking it with the sensors, or they just were tracking it manually, or noted in their record that they had a controller medication on plan. And then almost 75% were considered to have a baseline disease risk of kind of a medium burden, and I'll explain what that means. to really be able to look at both asthma and COPD in the same cohort. Jason needed to be able to look at what their baseline risk or baseline disease status was upon entry in the data collection phase. And it was really determined by bidding categories of impact based on the baseline scores on either the asthma control test for asthma participants or the COPD assessment tests. And again, these are self-reported, clinically validated questionnaires that then gives us a picture into what their kind of baseline disease status is. And then that information was used to really control for that baseline disease burden in the analyses, because we wanted to look at not the influence of the status of their disease in the beginning of the study, but really the influence of that changing air pollution signal over time. So in the smaller Southern California cohort, the sample size was smaller, it was just under 2,000 participants, but quite similar in terms of the descriptors. So still primarily asthma with about 89%, 70% female, had a mean age of 39.2 years. About 62% had a controller medication recorded in their medication plan, and 74% were considered at that medium baseline risk at the beginning of the data collection period. So really quite similar across statewide and Southern California. So now to move on into the methods and the results of the analysis on the impact of air pollutants on individual level daily rescue medication use. So in order to evaluate the association of each air pollutant by source with individual level rescue medication use, Dr. Su developed a linear mixed model. He used a GLMM-TMB modeling approach. And this was selected because it's quite good at handling over dispersion of an outcome, as well as the zero inflation that was present in the rescue medication use data set. The outcome was rescue medication puffs per person per day, and the exposure, so the air pollution exposure E, was assigned based on the estimate of the specific air pollutant for an individual participant per day, and that averages all of the individual exposures occurring within a day. We looked at NO2 and PM2.5 for all sources, as well as for port and railway source, and then also the additional, the 5 air toxics that we mentioned. Each pollutant was modeled separately. And then there was also one model that included both NO2 and PM2.5 for the port and railway sources to really try to understand that PM2.5 effect. So additionally, the individual participant characteristics were also controlled for, so including age, gender, that baseline disease burden, their medication adherence if tracked with sensors, and then also a weekly individual assessment risk, really based on kind of the weekly average of rescue medication use. Again, really trying to isolate that impact of the air pollutant on rescue medication use, holding all of the other factors about the participant and controlling for those. And then other confounding factors also included were weather and seasonality. And then lastly, Dr. Su included a random effect, which then helps to kind of account for the differences across individuals. So here are the results for the effect of air pollution on daily rescue inhaler use. So as you can see, both nitrogen dioxide and PM2.5 from all sources were significantly associated with rescue inhaler use. And just to give you a sense for the kind of scale, as an example, a per 10 ppb increase in NO2 was associated with about a 1.4 increase in rescue inhaler puffs per person per day. Well, it's kind of hard to think about a fraction of a puff per person per day. So we also kind of extrapolated that out to, if you considered this, like, what does that impact look like across the whole sample, a statewide sample? So across that whole 3,521 participants, that would equate to about an additional 49 rescue inhaler puffs per day. And if you then scale that out to a year, that would be about 17,885 additional puffs per year. For PM2.5, a 10 microgram per meter cubed increase in PM2.5 would equate to about 129 puffs per day, or over 47,000 additional rescue puffs per year across the entire sample. Then for port and railway sources, NO2 was not significant, but PM2.5 was significantly associated, as was the multi-pollutant model, which had both NO2 and PM2.5 together. And what we did see for the port and railway NO2 and PM2.5 model, we would estimate about a 10% increase in rescue medication use, puffs per person per day, per a 10 unit increase in air pollution. We also wanted to evaluate the interactive effect of air pollution and socioeconomic status. And so Dr. Su added an interaction term to capture socioeconomic status using the social deprivation index, or it's the, you'll hear me call it the SDI. So SDI is a composite measure of 7 demographic characteristics, including poverty, education, single parent households, whether the home, rental housing units, overcrowding in housing units, whether there's households with car access, and also the level of non-employed adults less than 65. And SDI is ranked from 1 to 100%. And so a higher SDI score indicates greater social deprivation or lower socioeconomic status. And so an SDI was assigned at an individual basis for each participant based on a geocoded home address. So we were able to get that kind of neighborhood level SDI. So to really understand the impact here and understand the effect, Dr. Su added that socioeconomic status by air pollution interaction term into the linear mixed model with that social deprivation index. All of the other variables essentially remain the same. So it included the outcome was rescue puffs per person per day. Air pollution was assessed at a daily level. Individual participant characteristics were the same. So controlling for age, gender, baseline disease burden, medication adherence, and then also controlling for weather, season, and the random effect across individuals. And so what we found here, so these are the results looking at, so stratified by low and high deprivation populations. So really based on the individual level deprivation value. And so deprivation low in the left, second left column means that those individuals stratified with low deprivation, which translates to higher socioeconomic status. Compared with deprivation high, which really means those individuals with high deprivation, also you can think about it as lower socioeconomic status. The interaction term for both nitrogen dioxide and PM2.5 and SDI and the social deprivation index was positive and significant for all source air pollution, both NO2 and PM2.5, and positive for port and railway PM2.5 as well, but that was not significant. But the effect sizes for the interaction show that the low deprivation group is much lower, that effect size of that interaction, and it's even negative for NO2 versus the higher effect sizes among the high deprivation group. And so this means that the interaction between air pollution and socioeconomic status is really larger for higher deprivation groups. So next, Dr. Su looked at the ratio of the high to low deprivation effect sizes to really evaluate the difference, the disparity in interaction effect by that deprivation level. And that's what's highlighted here in the red box. So we did find that for all source NO2, the relative effect was more than 2 times higher for the high deprivation groups versus the low deprivation groups. And for all source PM2.5, we found that the relative effect was more than 6 times higher for the high deprivation groups versus low deprivation groups. And so this really suggests a distinct difference and a disparity across the two groups, with the larger interaction of air pollution and socioeconomic status on the high deprivation, lower socioeconomic groups for the impact of air pollution on rescue medication use. For port and railway, PM2.5, we did see a 1.6 times higher impact, but it was not significant in this analysis. Okay, there we go. So now moving to the air toxics analysis, the model found that monthly benzene, lead, and zinc were significantly associated with monthly average rescue medication use. Chromium was directionally positive, but not quite significant at the P less than 0.05 level. Nickel was actually directionally negative but not significant. And previous research has shown an impact of toxics on respiratory symptoms, so it does confirm some of these findings. However, as Dr. Su pointed out earlier, there were some limitations in terms of the models used to develop the surfaces, so they should be kind of considered with that as well. So now we'll move on to the asthma-related ED visit analysis. So these were the statewide, and this analysis included data from 8,106 zip codes across the state of California. There was an average of 149.4 ED visits per zip code per year. So that's a minimum of, with a range of a minimum of 12 and a maximum of over 1,100. So quite a lot of variability per zip code. The ED rate per 10,000 people was a mean of 47.4 ED visits per 10,000 people per zip code per year. In Southern California, we had just over 4,300 zip codes, a mean of 161 ED visits per zip code per year, so a little bit higher. But then when you looked at the rate per 10,000 people is a little bit lower, so 43.5 ED visits, asthma-related ED visits per 10,000 people per zip code per year. So to evaluate the association of air pollutants on asthma-related ED visits per zip code, Dr. Su developed again a linear mixed model, but this was with a Poisson link, so to address counts. And where the outcome was the number of ED visits per zip code per year, and included all of the same air pollutants that we've looked at previously. So all source NO2 and PM2.5, port and railway NO2 and PM2.5, and the 5 air toxics. And again, each pollutant was modeled separately. We also had neighborhood level race and ethnicity, as well as socioeconomic status to help control for some of those impacts, and that's at a zip code level. And then we also had a zip code random effect also included to really try to capture some of those other unseen differences across zip codes. And then lastly, a zip code level population density was also included to really understand or control for that impact of density. And so as we can see here, both all source NO2 and PM2.5 and the port and railway NO2 and PM2.5 were significantly associated with asthma-related ED visits per zip code. Just to give you kind of a sense of the scale. So here, using NO2 as an example, per 1 ppb increase of NO2 would be associated with about a 3.9% increase in annual asthma-related ED visits, or a 10 ppb increase would be associated with about 39% increase in annual asthma-related ED visits per zip code. And so the effect is really cumulative across a year's time frame and across thousands of people. So I think that's one of the reasons why we see larger effect sizes here than the kind of daily outcome. And here we're looking at again, that interaction effect of air pollution and SDI, the social deprivation index, on asthma-related ED visits per zip code. And the interaction terms between SDI and air pollution were significant for all source NO2 and PM2.5, as well as port and railway NO2 and PM2.5. So that means that there is indeed an interaction effect between SES and air pollution in all cases here. The effect sizes for the interaction show that the low deprivation group is lower for all source NO2 and PM2.5 versus the higher effect sizes among the high deprivation group. So again, this means, similar to what we saw before, that the interaction effect between air pollution and socioeconomic status is larger for higher deprivation groups. So the ratio of the high to low deprivation shows about an 18% higher interaction for NO2 and a 23% higher interaction effect for PM2.5 for those in terms of the disparity. And so that definitely suggests a distinct disparity across the two groups for all source NO2 and PM2.5. When we look at the port and railway NO2 and PM2.5, the relationship wasn't as clear. It's significant, but actually flipped. And so we saw lower interaction estimates for port and railway NO2 and PM2.5 for the higher deprivation groups, which is interesting. So that may have something to do with kind of the way that things were modeled, as well as the outcome being aggregated at more of a monthly level. So that's something to explore further. So lastly, we saw significant positive association between benzene, chromium, and nickel on asthma-related ED visits. Lead and zinc were slightly negative and insignificant. And again, take a little bit of grain of salt with given the caveats that Dr. Su introduced in terms of the modeling results. But definitely quite interesting. So that was a lot. In summary, we have a table of the effects that were found. We're looking at all sources, port and railway sources, as well as air toxics. And then in the health effect column, the direction of the effect is listed in that column. The bold text indicates a significant result. And then the presence of a disparity, so that SDI disparity between high and low disadvantage, is indicated in the disparity column, again, with bold indicating a significant effect. And so air pollutants and toxics from multiple sources had significant effect on asthma outcomes. In the all source air pollution, we saw all source NO2 was significantly associated with daily rescue medication use and asthma-related ED visits. All sorts PM2.5 was significantly associated with the rescue medication use and asthma-related ED visits. So very consistent findings across both health outcomes for both NO2 and PM2.5 in all source. For port and railway sources, NO2 was positively associated, but not quite significant with rescue medication use. But NO2 was significantly associated with asthma ED visits. And then PM2.5 was significantly associated with both rescue medication use and asthma ED visits. And then lastly, for air toxics, to review that, benzene, chromium, lead, and zinc were positively associated with monthly average daily rescue medication use, although chromium was not quite significant. And then benzene, chromium, and nickel were also significantly associated with asthma-related ED visits. And as we walked through, we also explored, again, that interactive effect between air pollution and socioeconomic status. And we did find quite consistently a disparity in that interactive effect of SES and air pollution. Largely for all source air pollution, we found significant disparities with a larger interaction effect for those lower socioeconomic groups. And then additionally, we observed significant disparity effects for air toxics and asthma ED visits as well. So to close and kind of summarize all of the information that we've presented today, going back to the beginning with community input that showed really strong interest and understanding of the impact of air pollution and asthma. However, wanting more access to real-time data and knowledge of state-level policy would be helpful. We were able to, Dr. Su incorporated very diverse input data and used different sophisticated modeling approaches to effectively model NO2 and PM2.5 concentrations from both all sources, as well as source-specific port and railway operations with excellent model performance. Then also the air toxics models were developed, but did face some data input challenges with varying degrees of accuracy, and that's some work that will be ongoing. And then really using two pretty different health outcomes at different scales. So we had the daily individual level rescue medication use, so very sort of frequent and proximal signal, as well as the more annual kind of aggregated asthma-related ED visits per zip code per year. But we did find consistent impact of air pollutants on both of those outcomes from 2012 to 2019. Air pollutants and toxics from multiple sources from all sources had significant and consistent effect on asthma outcomes. And we also did identify significant interaction effects between air pollution and socioeconomic disadvantage, with the effect within disadvantaged areas ranging as high as 6 times higher than advantaged areas. And definitely there's a lot more work to be done to continue to refine these research findings, share them, and help connect them into policy information, as well as with asthma stakeholders in the communities that we explored. So with that, we wanted to thank California Air Resources Board very much for the support of the study, including all of the project management and the funding, and all of the feedback on the protocol and the analysis. It's been invaluable. Thank you for attending today and listening. And then also thank you to the stakeholders who conducted all of their interviews and informed the research project from the beginning, and then also to all of the collaborative team members. So I will stop sharing there, and I'll hand it back over to you, Margus.
Thank you, Dr. Barrett, Dr. Sue, and Joel Arbis for the great presentation. I will now go over some summary slides. Let me share my screen. Okay. Okay, it's coming to the full screen. You can see my full screen, right?
No, we saw 2 screens.
Yeah.
Oh, yeah.
Okay.
Yeah, it is.
Okay.
Thank you.
It's not. Okay, so yeah, so I'll go over some the summary findings from this project. For both port and railway exposure, and all source NO2 and PM2.5 exposures has significant impacts on emergency department visits. The communities that are socially deprived had experienced higher burden. As Dr. Su mentions, more study is needed to confirm this result. There were a limited amount of air toxic exposure data available, as Dr. Su mentioned. But despite of the limited amount of data, these air toxics were associated with increased medication use and ED visits. So further study on air toxic exposure will be needed to confirm the results. For rescue medication use, increased medication use was found with exposure to PM2.5 and NO2 from all sources. For the whole state of California, for a sample of 3,500 people, this was equivalent to additional 49 puffs per day for 10 ppb increase in NO2 exposure. Increased medication use was also found with exposure to PM2.5 from port and rail operations. This estimated a 10% increase in rescue puff per person per day for a 10 microgram per cubic meter increase in PM2.5. Medication use was increased about 3 times from port and railway exposure in the highly impacted communities. Disproportionate burden of air pollution was found in the socially deprived communities. NO2 exposure had 2 times, and PM2.5 exposure had 6 times greater effects on medication use in the highly impacted communities. So those are the summary slides. I'll stop here and we will open up for questions.
So, hi, this is Barbara Weller with the California Air Resources Board. And at this time, we're going to open the talk up for questions. I just want to start off by thanking Dr. Su, Dr. Barrett, Joel, and the team for all the work that they have done in this study. Obviously, this has been a very important study for the California Air Resources Board, really pointing out the effects in disadvantaged communities and the equity issues that are of such great concern for the board, as well as pointing out with the work that RAMP did and the team did to think about some of the interaction and the outreach for our organization. I think that's going to be extremely helpful for us. So at this point, we're going to open for questions, and I think you know, if you can raise your hand, you can put questions in the chat, and we'll probably start off with raised hands questions first before going to the chat. So I see some hands starting to raise. So I'm going to go on mute, and Nargis, I'm going to let you go through and tell the participants to start asking their questions. But thank you again to the team.
Thank you, Barbara. So Doug, a singer, you could unmute yourself and.
Hi, thanks so much. And really interesting presentation. This is a question for Dr. Barrett. So I'm trying to get a sense of whether if you had the opportunity to reduce emissions near port and railway communities for, let's say, NO2 and PM2.5. And I'm looking at the slide. I don't have a slide number, but it's the one where you showed the interaction effect between air pollution and SES on rescue inhaler use, and you had a red box around the high-low ratios. And in the lower part for the ports and railway, you said the findings weren't statistically significant, but it looks to me like the impact was about 2 to 3 times greater in the lower socioeconomic communities. So without that statistical significance, my question, sorry, this is a long introduction, but my question is do you think it's appropriate to say that reducing NO2 and PM2.5 emissions and resulting concentrations is perhaps 2 to 3 times more valuable from a public health perspective in lower socioeconomic communities located near ports and railway facilities than it is in higher income areas?
Yeah, great question, and a very good sort of application of these findings to the real world. I think, and I have that slide, actually, I could probably pull it up, but so we did see, again, it was the 2x, let's see if I can show this here. Can you all see that? So the 2x high-low ratio for NO2 all source, over 6 high-low ratio for PM2.5. And then we did see directionally the same sort of effect or the same size effect, interaction effect for the port and railway location. So 1.63 and 2.80. So that seems pretty consistent. Again, we didn't see that statistical significance, but I think directionally that kind of points us in the same direction. I really, and Jason or Dr. Su can comment more on the methods and the input sources, whether, the sort of averaging of the rescue medication use to a monthly level and then the monthly assessment of the port and railway concentrations kind of weakened that significance a little bit. But I think directionally, given that they're both, heading in the same direction and similar sizes, I think would support the fact that, yes, we do see a higher impact in disadvantaged communities.
Thanks.
I do agree with the Doc's assessment. So it is, but it's based on the model. Of course, because now it's kind of monthly, right? We can go to daily, but the basically the exposure doesn't support that way, because the emissions were provided at annual level. We only gone to monthly based on the meteorological condition we could do. So we could not go even further than the uncertainty would be even greater. But based on the monthly results or the associations through the stratification, we still find for the deprivation high compared to deprivation low communities, the effect is 2.8 times if you have model incorporating PM2.5 and NO2, use NO2 as a confining control. So it is it's basically per unit increase of PM2.5 would have much greater impact on the deprivation high or socially disadvantaged communities compared to the socially advantaged communities.
And then Jason, can you also confirm, my understanding is that the port and railway PM2.5 and NO2 were included in the all source. So the all source is inclusive of multiple sources, including port and railway. And so it does, it's a more robust sample, again, sampled at a daily level.
Oh yeah, for the all sources, they have the impact of the port and railways. That's part of the predictors, so the emissions. But at that time, the emissions is only at annual level, right? It doesn't change from day to day when you build the 90 years regression model.
Great question, thank you.
For us, we could go to daily, but it doesn't support the data. Too much uncertainty. Even the size increase, you have so many subjects and so many rescue paths, you might be able to get significant results, but that doesn't say much about the actual effect due to the uncertainty of exposure.
Yeah, we have hand raise, Maninder. Can you?
Yes. Hi,
Yeah.
This is Maninder Thind. Thank you for the great presentation. Really nice study. I just had one clarifying question I may have missed in the starting. I just wanted to clarify on the emission sources from, the ports and locomotives, PM2.5 and NO2. Does it include both stationary, the operations at the ports and the railway stations, or does it also include the mobile, from the mobile movement of the locomotives within the region? So if you could just clarify on the emission sources, what's included?
Okay, the emission sources, for the predictors, we have traffic, we have those for air toxic, you have also the industries, right? For all sources have those impact too. But for the port and railway specific sources, they including port operation, like for the ports, so including all the emissions from the cargoes plus the mobile source, the vehicles going and out of the ports, but also the crafts, some of the crafts lifting the cargoes, those impacts are also over there. For the locomotives, many operating on the trains, but also have the like switches. So the crafts operation are all included over there. Those are based on the TOPS estimates, California Air Resources Board, but the estimation was not for the ports. The more specific is one port is one port, right? We use that as point source or it's a small area source. But for the railways, because extending a large area, the emissions estimated by COP, so at a sub-region level, like you go to Los Angeles, and they have 3 sub-regions. So the northern part, like mountainous, middle part, and also southern part. So those ones are not location specific. For us, we used the distribution of the like the railways, also switches, or the different types of operations like long-haul, small distance travel, and the switches, and those kind of information to get it into the location-specific emissions. Then after we generate the emissions, because the annual, so we assume the same for each month. Then we modeled through the scaled model. So does that answer your question, Melinda?
Yes, thank you. So it includes the area sources, as you said, and also the line sources.
Oh, yeah.
Okay. Thank you.
Thank you.
Anybody wish to ask question? You can unmute yourself. Bonnie? Unmute, please.
Yeah. Sorry. Thank you so much, all of you, all the collaborators, and Dr. Sue for leading this project. I think it's very important, as Barbara said, to our understanding of health impacts in highly impacted communities. I'm wondering if you all agree on, you discussed several areas where you think there's additional research needed to further confirm findings and to explore some of these new areas, including the air toxics. I wonder if you all agree on what is the most important area for further research coming out of this study, or if you would prioritize among some of those areas you indicated.
Okay, I can go first. Meredith and Joe can provide her thoughts. So for me, as a researcher, I always wanted to have very fine resolution of exposure modeling and also the services. So that's always my goal. So for NO2, PM2.5, and also source specific through the port and railways, I think I'm very satisfied with what we have done. But for the air toxics, benzene is the one is reliable, but other than benzene, most of them are not as good as what we expected. So I have done some of the minor additional analysis. We find that we improved the predictions already. So my goal is from the ongoing study or other future studies, I will find a way to improve the air toxic modeling. That's the key for my future efforts. For the outcomes, we would, if possible, we would like to use more data from per house to have more data available once we keep going. To get closer to current periods, have more and more data. We could use similar data like rescue medication paths, but they also have claims data now. So they have specific claims data. So we could use those ones to have ED visits, hospitalizations associated with individual patients or the say patients, the participants for the group. So I think that would be a great effort to find the and I cannot say exact, but it's a very much better impact identification of the effects of the air toxic rescue medication use. We could also like right now we use ED visits, zip code levels, right? We could also use other data sources like the ones I'm working on. Like we could have the house care access and information. So I have the Department of Healthcare Access and Information that have the ED visit hospitalization at the individual level. That can cross many years. So that would be a very good way to identify, because that's the statewide, so patient level data. So that would be a great one. But we can discuss this later when you have time, and also you can seek use information and also the collaboration with Propeller House and also other organizations.
Yeah, I think Jason raises a good point. I think looking at the two different health outcomes is a really interesting kind of diverse way of looking at the impact on asthma. But I think it would be very interesting through a kind of a tokenization process and a linking process where we were able to get some de-identified claims data for individuals. And so then you kind of have the full picture of both the rescue medication use as well as those more acute claims, ED visits, hospitalizations, doctor visits as well. So you could kind of have the full picture on the individuals in the study in terms of the impact of air pollution on those outcomes. So I think that is really interesting. And then I think multiple times as we were doing this study, we talked about how interesting it would be to see. We studied through 2019, but to be able to see then you have this natural experiment almost of COVID changing how we move and changing our traffic patterns and changing, railway and port activity. And you see the kind of drop and then the increase in goods movement post 20, in the 2020, 2021, 2022. So I think that kind of comparing those different time periods would be really fascinating. And see whether we see a signal shift in the impact on health outcomes as those kind of different sources shifted during and after the COVID pandemic.
Thank you. And Joel?
Yeah, I would just add the couple of things. I think there were some interesting findings, and Meredith, in the Q&A and in your presentation, you noted that there were maybe some surprises, right, in terms of the some of the findings not being statistically significant, but being directional, right, in terms of an association. So would love to learn more about the thinking around, or the, looking more into that piece, right? Is it a modeling issue? Is there not an association at all? And then I don't know that I'm going to be able to articulate it well, but there was another finding where the ratio was flipped, basically, where it looked like in less disadvantaged communities, the impacts were higher. And that struck me as inconsistent with kind of our general understanding. And so, learning more about that and thinking through what's going on there, right? Again, is it a modeling issue? Is there something else at play? Would be really fascinating. And then maybe this is less research, just more around communication. Everything that you all covered today was really fascinating and obviously incredibly complicated. And so thinking about how to communicate this information to the broader public, to the communities that were studied, et cetera, I think would be great too, just to help streamline it a little bit and share the excellent information that was covered in the study.
Yeah, I had a conversation with Meredith about the switching the ratios. So at the individual level, the rescue medication use, right? They are in the right direction. But once you go to the ED visits, the ratio switch. I think the main reason is that, especially for Southern California, the zip codes are big. And also, once you assess the exposure, the zip code level are high, but that totally covers the within zip code variations for the individual ones. So once you go to individual level, you can identify those variations. But once you go to zip code level, you don't, because most of the zip codes have higher exposures. So that's why part of the reason we saw those relationships switched. So at the individual level, it's more accurate because based on time and space of the location. That's why I like collaborating with Meredith. The collaboration with Propeller House, that was 2 years after the company was funded, we find a common point to collaborating, because you basically go away from typical research using home address, to use locations, right? So they can track the rescue medication use, but also non-use. Non-use, even though it's for binary information, but every 2 hours, 4 hours, they know exact location, what people want. So the exposure within a day can have multiple locations, sometimes more than 10 or 20. So it's a much better way of identify activity space. And then that's more accurate in the exposure space than based on zip code level, just use the aggregated zip. So that's why it has a difference.
Thanks so much.
Thank you.
Looks like there's a question in the chat.
Yeah, I'll go. There are a few questions. One of the question was, is the work published? I know that it's not, so Dr. Su can.
It's not a published yet, but we are working on the publications process.
Yeah, okay, thank you. And then, let me see. Yeah, well, one of the comment was to be careful about mobile source emission models using per vehicle distance rates because they greatly underestimate the low speed emissions.
Can you say that again?
Leonardo states to be careful about mobile source emission models using per vehicle distance rates. Can you see that?
Yes, that's me.
Okay.
Problem is that the distance goes to 0 at low speed, but the emission rates don't go to infinity. So a lot of times they'll analysts will change it to per unit time rates at low speed, and then do a projection from down from 10 mile an hour rates to idle rates. So I want to make sure that you don't get caught into thinking that the rates in the model are correct at low speeds. It sounds like you're using larger areas, so probably didn't get into low speed rates in the analysis. So it's actually a question I was going to ask. You're talking about zip code emissions as opposed to rail side emissions or idling drayage vehicles. So did you manage to avoid any issues on low speed emissions?
For the emissions, you mean the source specific, like based on the locomotives or those railway locomotive operation speeds?
Oh, well, locomotives certainly, and I'm not sure whether the engines are still running when they're sitting there. Probably depends on the engine type and so on.
Yeah, that's good.
Electric.
That's a very good question. But for me, because the emissions is aggregated by the annual, they do include the locomotive operation, like the traveling, and also the idling, and also some of the switches operation. So not traveling. All those sources are included into one emission sources estimation for the entire sub-region based on the California Air Resources Board.
Well, you were referring to detailed information too. So if you're aggregating it, you're losing the low speed rates. But actually, if you go to time-based rates as they do for project studies, then those are moderate rates at low speed per unit time rates.
Yeah. I totally agree with you. But we could not disintegrate or aggregate those onto that detailed, spatially. It's almost impossible because we do not know the travel speed, and also all the information underlying the estimation of the emissions. So the information we could only get for the emissions is the annual emission estimated total for all the activities associated with ports and also the locomotives and railways.
So it sounds like you avoided the problem by taking larger geographic aggregations.
Yeah, there are large area annual aggregations. Basically, like for LA, one country that have only 3 sub-regions, but they also have the distribution of the railways, right? And also switches. They have the total volume for each type of the railway systems. So I just based on the total emission within a sub-region to disaggregate or distribute them spatially into each type of railway operations. It's still aggregated at annual level.
So this is Bonnie Holmesgen from ARB. I really appreciate the questions, but I'm wondering if we can move. We have 3 more questions, and we're kind of diminishing on the time we have left. And maybe if there's additional questions on this topic for Dr. Sue, Leonard, Seitz, you could correspond with Dr. Sue, or Dr. Sue could reach out to you and kind of finish up this conversation. Would that be okay? Okay.
Thank you. There's one raised hand, Sylvia.
Hi, good afternoon. Oh, excuse me. Sylvia Betancourt with Long Beach Alliance for Children with Asthma, based at Miller Children's and Women's Hospital. Nice to see you all. Thank you very much for carrying out this research. I think this is what we have known all along and now is validated. And it does continue to raise more questions, particularly when we think about the data, the period that you were looking at, and where we are now, where some of these, where the industries have really, they've been reporting record volumes of movement of cargo containers right through the, through the ports of LA and Long Beach and up through, our communities. Warehouses have boomed since the pandemic. So I think, Meredith, you make a very good point in furthering the study to explore what does that comparison look like today. And I say that in particular because of the communities that we work in. They're the ones who are experiencing this, right? So this story that you're telling is what our community members are living, what our children that are enrolled in our program are living. And so I really wanted to exemplify that, like if that's something that could be further explored, I think would be extremely valuable. Although what you have right now is very helpful. I think as well, if we could continue to talk about how to communicate what you've shared in ways that are practical, that that we can continue to share with our community members, that I think would be extremely valuable. Something in the form of perhaps an infographic or just highlighted key points, I think would be valuable. And I would like to continue the discussion offline, if that's an opportunity in the future. So thank you again.
Thank you.
Yeah, thank you, Sylvia. Those are great questions. Thank you for raising those questions. We could share with you a lot of information, like the hotspots, right? We have all those ones focus on the Long Beach and those places, very high resolution. The models were developed at 30-meter resolution, but we have that produce the surfaces of 100-meter resolution. Your OVG, you might also check with the USC professors, Robert McConnell. He's doing another one on the specifically on the port. That's also funded by COP, I think.
I missed a meeting with him to be at your meeting right now, just FYI.
Okay, good, okay.
And I also wanted to add, so, in terms of zip codes in Long Beach, there's a community health needs assessment that found that in Long Beach in particular, there are specific zip codes where the mortality rate is lower than in others. And that could be as big a difference as 7 years. And so I just wanted to talk further with you about overlaying some of that data with what you found, because I think that could be just something that is very telling for the ways that some of our communities are essentially being sacrificed for some larger issues that really are just they're essentially a public health crisis. So I'd like to follow up.
Okay, great. Yeah, talk to Robert McConnell and we can talk together.
Thank you
So much for those comments, and absolutely agree. And I think the idea of an infographic is a great idea, something to really kind of simplify the results. This is a very technical presentation, but we'd love to chat with you and get your input on what would be the most impactful way to do that. Thank you.
Thank you, Meredith. One more question. Is the project data, specifically the health data, hospital visit records, socioeconomic data, are open source to be used by other researchers? I don't think so.
Oh yeah, no, for the visit hospitalizations at the zip code level, so all open source.
Okay.
But not for the rescue medication use data.
Okay, thank you.
So I would just add that the rescue medication use data, since it's at an individual level, that's considered protected health information. We can, and through sort of authorized RARB reviewed research projects, we can consider sort of research applications of the data, but only in a de-identified way. But yeah, just feel free to reach out if that's of interest. And then all of the socioeconomic information, Jason, that was all, or Dr. Sue, that was all public information as well, correct?
Mm-hmm. Thank you. Last question, Doug. He added one more question. What would be the relative ratio of impacts for disadvantaged communities versus the average population? The ratios shown are disadvantaged areas versus high income areas. If it's correct, in other words, is disadvantaged communities experiencing 2 to 6 times greater impact than higher income areas? What is the ratio for disadvantaged communities compared to an average representation of the general population?
Mark knows this too well. Okay, so basically once we do a stratification, so you have the basically being stratified into 3 types. One is highly deprived, right? That's the most disadvantaged. You have also the most advantaged, the second, but also a median, that's the middle part. We only present the results for the most disadvantaged compared to most advantaged. We could compare to the middle part too. So 4 in between. So you can say roughly half, but I'm not sure. We need to use actual stats if we wanted the results.
Okay. Thank you. So that's all I can. Oh, there's one more. Was the study able to determine which sources within ports, ship trucks, equipment, etc., were the primary contributors to pollutant emissions?
Sorry, can you say that one more time?
Yeah, was the study able to determine which sources within ports, ship trucks, or equipment were the primary contributors to pollutant emissions? Which sources?
You mean the all source model or the source specific models?
I think they're talking about the source specific model, Dr. Sue. And I think they're trying to figure out if the ships or the trucks or maybe the port equipment was the major source of contributing to the port and rail pollution. Was it you know, can you differentiate between, I don't know if you when you aggregated the sources, if you actually looked at the sources separately from ships versus trucks versus the port equipment.
Yeah, unfortunately, we didn't differentiate them. We just added them up. We could explore that further based on the
Right.
the emissions inventory. It's a have those tons, how many tons of emissions for each source, like cargo or the crafts or the mobile vehicles within the ports. So to have those total emissions.
Okay. Thank you.
And that's all we have. Yeah.
Well, we're slightly over our time, and I really want to thank all the participants for being part of this. You know, we had over 100 participants, and we still have nearly 50, and we're even beyond our time. So I really do want to thank everyone for their questions. I want to thank the presenters again. And I also want to thank the whole team for the work that's done a lot of things for us as an agency to think about. And we look forward to going through this and the publications that are going to be coming out. So thank you all for participating and for joining us today.
Thank you, everybody. We conclude our seminar. Have a good afternoon. Bye-bye.
Bye.
Bye-bye.
Bye.